Okay, so this afternoon, we're going to look at vaccination as a powerful tool to fight antimicrobial resistance from Fleming to Pasteur. And on this slide, you'll also see Pandora as she peeks into a box, and in this box, and it actually came about that it wasn't a box, but just a little container. But she then unwillingly or unknowingly unleashed evil into the world. And she managed to just close the box in time to save hope, humankind's only solace. So similarly today, we've been tasked with really exploring the interplay between two of these great treasures that we still have today. And my colleague, Hannelie Meyer, really is the head of SAVIC and works in vaccines every day. And as you all may know, I'm very passionate about stewardship and antimicrobial. So we are really very, very excited to join you this afternoon. Let me just quickly advance. Okay. The overview, immunization and the landscape, some strategies to combat AMR, evidence of the success of vaccines, and then the future AMR challenges and opportunities for vaccines. So if we look at from Fleming to Pasteur, we know that Alexander Fleming and Louis Pasteur were to be some of the most influential biochemists in history. And with their discovery in penicillin and Pasteur's development of vaccine, it has saved millions of lives up to date. But I always think that the poor Edward Jenner was almost like the orphan child, and that people forget that he was actually introducing vaccines into the larger population. And since then, vaccination has become a widespread medical treatment, and it has controlled 16 major diseases already. But amongst all of these facts, there are always myths, like we have in Greek mythology. So we always have the enduring Prometheus that's trying to help humans. And then we've got the Minotaur that is trying to destroy, it devours all of the evidence. And I often think of some of the anti-vaxxers. And then Medusa, whose beauty turned into snakes. And then Narcissus, who could not love anyone other than himself. And I think if we don't share vaccines, it's almost, we can almost relate to that we don't share all of this with the population. So if we want to understand the current landscape of the interplay between AMR and vaccines, it's good to think of Atlas. And he was the Titan god who bore the sky, and he really had the quality of endurance. And he gave mankind the art of astronomy, which we still use to navigate. And he is also the god who turned the heaven on the axis, causing the stars to revolve rather. And if we look at what is currently happening and how we can navigate this landscape, this is a nice paper that was published in the Lancet of 2022 that looked at the global burden of bacterial antimicrobial resistance. And it estimated that more than 95 million deaths were associated with bacterial AMR in 2019. And this actually included 1.7 million deaths attributable to bacterial AMR. And if we look at this data at a regional level, and it's been highlighted on the slides, the all-age death rate attributed to resistance was the highest in West Sub-Saharan Africa, at more or less 27 deaths per 100,000. Lower respiratory tract infections, which we're also going to discuss today, in 2019 accounted for more than 1.5 million deaths associated with resistance. And then in this paper, the 6 leading pathogens for death associated with resistance was Escherichia coli, followed by Staph aureus, Klebsiella pneumoniae, Strep pneumoniae, Acinetobacter baumannii, and Pseudomonas aeruginosa. So I think another important part that I just want to mention here is the global distributive equity, especially in Sub-Saharan Africa. And it's not just the distributive equity of vaccines, but it's also the distributive equity of antimicrobials. And if we don't have access to antimicrobials, or if we don't have access to vaccines, then in vaccines, in antimicrobials, in stewardship, it leads to resistance. But in vaccines, it really leads to an ethical crisis. And we've seen this nicely displayed in COVID-19, where we had 13% of the world's population that procured 51% of vaccine dosages. And I think this is, when you look at it as an ethical principle of benevolence, an individual can offer benefit of this scarce resource to another with relatively little cost to themselves. It's considered a morally acceptable choice to have both of these resources available. And then we can also look at principles of global distribution according to justice. And there's egalitarianism, sufficientarianism, prioritarianism. So to reduce inequalities, the right to a minimum decent life. And of course, with vaccines, improving the situation for the worst of the society. So when you look at some of these aspects in interplay, one really can't separate the one from the other. So could antimicrobial resistance be the next pandemic? I don't think we must add the word could there. It's already there. It's one of the most, it is the most silent pandemic of antimicrobial resistance. And it's increasingly claiming the lives of patients in clinics and in hospitals. And we are now gradually and more progressively facing this silent emerging pandemic. And it could really take away and endanger one of the most significant advances in modern age. But when it comes to vaccines and AMR, there are many papers now that actually link these two together. And this was a nice highlight of the article that I'm going to discuss now that was highlighted in March, or no, in July of 2023 by the WHO, which actually state that vaccines could avert 500,000 deaths associated with antimicrobial resistance per year. And vaccines is a valuable tool in the spread of AMR with other measures. And the other measures is also important. It's access, again, access. If you look at global distributive justice, water, sanitation, hygiene, especially in healthcare facilities. So even though we talk about vaccines and AMR, some of the principles in basic IPC is also important to remember, along then with diagnostic tools. But vaccines clearly contribute to a decline in infections amongst vaccinated and then, importantly, unvaccinated populations. And then it reduces the need for antimicrobials and then reduces the risk of misuse. But then I think it's important to remember that globally, this integrated strategy to combat antimicrobial resistance, it's important to remember that no single response is sufficient. In reality, we know that to stem this rising tide of AMR, antimicrobial research and development is silent, or it's challenged with the development of novel and effective antibiotics. So vaccination against other measures is a solution that has been undervalued in many instances, and it directly reduces the incidence of sensitive and resistant infections. And it also reduces both appropriate and inappropriate use of antimicrobials by reducing the overall disease incidence, and thereby including viruses and the viral incidence, the interplay between viruses and bacteria, for example, influenza, that are often inappropriately treated with antibiotics. So we need a global strategy. Okay, and then this is a very nice paper by Rossini, Vaccines Against Antimicrobial Resistance. And this study actually depicts that life expectancy has generally been between 25 and 35 years. So I would have already been gone by now. With infection diseases really being the balancing needle, the living conditions of humans are progressively becoming improved to the point that nowadays, if you live in a high-income country, you can expect to live more than 85 years. But what this study has really showed us, the results that they've achieved, is by improving hygiene, antibiotic use, and vaccination, these three pillars have represented the most effective medical intervention to reduce mortality and morbidity. So it's hygiene, rational use of antibiotics, and vaccination, but where you have hygiene in place. So globally, AMR pathogens are causing 700,000 deaths per year and 10 million deaths per year. And by 2050, a number even higher than 8.2, which is the number that is caused by cancer today. This is a paper by Adrian Brink and Prof. Richards already and Guy Richards in 2017. And what makes this paper, what this paper really highlights is that since the introduction of PCV in South Africa in 2009, followed by PCV 13 in 2011, led not only to a dramatic reduction in penicillin by 82% and ceftriaxone-resistant pneumococcal infections by 85%, but also to multi-drug resistant diseases, 84%. It's quite a significant reduction. And this is the paper that I discussed a little bit earlier, but it's been released and it's now been circulated by the WHO. It was a study that was initiated or was requested, or I can't remember, but managed by the WHO. Apologies. Okay, so this study actually found, as I've mentioned earlier, that over 500,000 lives could be saved every year with the effective use of effective vaccines. And what they did is, what you'll see there is actually a static model, a static proportional impact model. And they estimated the reduction in pre-vaccine AMR burden after vaccination in direct proportion to efficacy, coverage, target populations for protection and duration of protection of existing and potential future vaccines. But what is important to remember about the static model is that the burden, the AMR burden, could differ between, for example, infants and, if you think about the elderly. For example, AMR burden for Streptococcus pneumonia and Haemophilus influenza would be higher amongst infants compared to the elderly, whilst AMR burden for Staph aureus and Acinetobacter are lower amongst infants compared to the elderly. So having said that, when you look at the results that they found, they used data from 2019 to model the potential impact of 50 new and existing vaccines against pathogens in the WHO's list of bacterial priority pathogens. And they found that if vaccines are used for the key populations, not only could 500,000 lives be saved, but 28 million disability-adjusted life years, or DALYs, would be adjusted, meaning that the number of years lost to disability or reduced lifespans as a result of infection. So in the scenario where we maybe have 7 of the vaccines were used for broader population, an additional 1.2 million deaths and 37 million DALYs would be prevented. And the biggest reduction, as would be felt in the WHO African and Southeast Asian regions, which currently accounts for 2/3 of vaccine preventable AMR burden. Okay, what about maternal vaccination? And when you think about maternal vaccination, we cannot think think of anyone else rather than Gaia. And Gaia in Greek mythology was seen as the mother, as the earth itself, the mother of all life. And she bore many gigantic and powerful children like Uranus, Pontus, and Uria, so the heaven, the sea, and the mountain. So this is also a study that looked at preventing antimicrobial prescribing amongst infants following maternal vaccination against the respiratory syncytial virus. And this, the RSV is a leading cause of acute lower respiratory tract infection, of course, as mentioned earlier, a big burden in Southern Africa and amongst infants. And when you look at previous studies, they have reported that there's an increase in pediatric antimicrobial prescribing during these periods where we have greater RSV circulation. So, and then the RSV also facilitates interactions between strep pneumonia, Haemophilus influenza, Moraxella, and others, which we see also in upper respiratory tract infections in children with acute respiratory symptoms. This study was a double-blinded trial that was undertaken in 11 countries, infants born to mothers who were randomized to either receive an experimental vaccine against RSV or a placebo. And what they found is that they experienced a nearly 13% lower incidence of antimicrobial prescribing over the first 3 months of life than in infants whose mothers were randomized to receive placebo. And just interesting to note that while the lower respiratory tract episodes accounted for 69 to 73% of all antimicrobial prescribing prevented by maternal vaccination, striking with a very striking vaccine efficacy of 71.3%. This was observed, the 71.3% was observed against acute otitis media associated antimicrobial prescriptions in infants in higher income countries. So really just also highlighting the interplay between vaccines and bacterial infections. It's a paper, this was a phase 3 double-blind trial conducted in 18 countries that looked at bivalent prefusion F vaccine in pregnancy to prevent RSV illness in infants. It was published on April in 2023 in the New England Journal of Medicine. But they had two primary efficacy endpoints. It was the one was medically attended severe RSV-associated lower respiratory tract illness. And then it was done against different dates, 90, 120, 150, and 180 days after birth. And this is some preliminary results that they showed, pre-specified interim analysis results, where they looked at the criterion of vaccine efficacy just at the number of infants who were medically attended to at those dates. And they found that it was effective against medically attended lower respiratory tract illnesses in infants, and no safety concerns were identified. At the moment, they also stated it's reported as percentages and confidence intervals, and it is the number of attended visits has greatly reduced. But I'm looking forward to seeing the second primary endpoint when this trial finishes. Then vaccination and AMR. Cassandra's philosophical approach. She was the princess of Troy and she could see the future, but she was cursed that no one else would believe her prophecies. And I think that's also how we sometimes, or I at least sometimes, feel, even though I don't have any prophecies. Okay, so what are the pathways through which vaccines can counteract AMR? There are several: sensitive and resistant disease incidents, viral infections, misuse of antibiotics, and mechanisms of action. And we've discussed many of these, but I think what's important to mention here is that vaccines have been able to overcome the evolution of resistant strains. And there are several reasons for this phenomena. First, vaccines are used prophylactically when a pathogen population is still relatively small, lessening the likelihood that resistant conferring mutations will appear and proliferate. You think about the mutant selection window, which is a huge target for pharmacokinetics and dynamics. And second, many vaccines target populations in multiple ways, so requiring multiple mutations to confer resistance. And finally, when you have rare instances in which resistance to vaccines has been detected, disease reduction can still be attained because you can just have better vaccine targeting to avoid potential future problems. And if we look at the AMR bacterial pathogens and the treatment with all of our currently available first-line antibiotics is often ineffective against resistant infections. And then when we use second-line antibiotics, may be required to resolve the infection. However, then again, the use of the second-line antibiotic may promote the emergence of new antimicrobial resistant isolates resistant to our second-line antibiotic. So at a population level, the emergence and spread of antimicrobial resistance leads then to difficulties in treating these infected patients. So pathogens resistant to antimicrobials then causes substantial morbidity and death in these populations. So what would be the effect of vaccines on AMR? So vaccines against AMR-resistant pathogens could prevent or reduce life-threatening diseases and decrease healthcare costs, and also reduce the cost of antibiotics. So, and the use of antibiotics, and then further potentially reducing the emergence of AMR. So if we have sufficient vaccine coverage, and the word there really is sufficient vaccine coverage, then we could have indirect protection in herd immunity in many of the instances, and it can then prevent or spread the resistant strains, reducing the disease burden and reducing the need for antibiotics. And again, you can see direct and indirect effects that is mitigated by vaccines. Okay, I'm handing over to my colleague, Hannelie.
Thank you. Thank you very much. Okay, so Natalie, you will forward the slides for me as I go along. And
Yes.
yes, I'll also turn off my video while talking in the interest of bandwidth and so on, where we live here in South Africa. So thank you very much for the opportunity to share this afternoon with you. And Mark, I'm really very impressed with your lovely setup that you have there. It looks so warm and comfortable. I can only wish on this side of the world. So thank you very much. And I'm just going to go ahead now. I'll just switch off my video. So there are reasons why vaccines are an important tool against antimicrobial resistance. So one of the first ones is that you know, we just know that resistance is absolutely inevitable when we are using antibiotics. So each and every time an antibiotic is being introduced, it becomes, you know, in the end, it becomes obsolete. So that we now are facing this pipeline of new antibiotics is now completely dry. And I often also always warn my students against that. In contrast, on the other side, vaccination has the benefit of sustainability, and it can be used for decades without generating significant resistance. So up to this point, we've seen that we have been able to overcome the evolution of resistant strains to a large extent with vaccines. And vaccines also, because they are being used prophylactically when the pathogen populations are relatively small, lessening the likelihood in the end that resistance conferring mutations will be there in the end. So secondly, also, many vaccines target pathogens in multiple ways, requiring multiple mutations to confer resistance. So in rare instances, we would then see the situation where resistance to vaccines has been detected and the disease reduction has still been attained. So the next reason, you can move to the next slide, Natalie. The next reason is that vaccines are in the golden era, and I think we've seen it now very clearly during the COVID-19 pandemic. So opposed to antibiotics, where we see that the pipeline is dry, with vaccines, there are so many new vaccines being developed at the moment, while we haven't seen many new antibiotics over the last number of years. So on this slide, you can actually see a review that was done and published in 2021, where there are several candidate vaccines in different phases of development. And as you can see here, most in this table is still in the preclinical testing phase, and just a few of them in the clinical development. But AMR is really a very urgent, like Natalie has said, it's a global threat. And a lot of focus now need to go into the development of new vaccines, which have promising solutions to the problems that we are facing. If you're going to go to the next slide. So this is a more recent review that was published in the Lancet this year. And here you can see they've also grouped the pathogens according to the vaccine candidates in development or already licensed. And in Group A, look at Group B, you can see it's late stage clinical trials with high development feasibility. Group C is early clinical trials, and there's moderate to high development feasibility. But if you look at Group D, there is really, you know, a small number or no vaccine candidates at this stage in the pipeline, and there's very low development feasibility for developing these vaccines, despite the fact that, as you can see, there are 94 active preclinical vaccine candidates at the moment and 61 active development vaccine candidates. And the whole process of vaccine development is very, very complex, and many people don't understand it and don't realize the complexity which goes into developing the vaccines, and also the specificity for how these vaccines should work in the different platforms. So if you can go to the next slide, please. So reason number 3 is that vaccines preserve the microbiome, which is also very important. Antibiotics, we all know it disrupts the human microbiome, and which has then harmful effects on various things, general health, especially children. So this disruption can alter the immune system's development negatively, and also affecting nutritional status. In repeated use of antibiotics also a problem, where it can create a reservoir of host-specific resistant genes in and organisms. The 4th reason is the potential for vaccinations to affect resistant infections. And Natalie has shown quite a number of examples where we have lots of evidence of the direct and indirect impact of vaccination on resistance. So in terms of reduction in a resistant invasive disease like pneumococcal, reduced circulation of resistant strains, and then reduction in antibiotic consumption and also antibiotic prescribing. You can go to the next slide. So this is just an example of a meta-analysis showing the benefits of influenza vaccination. As you can see on the left, the number of antibiotic courses or prescriptions significantly lower in people who did receive the influenza vaccination. And then on the other hand, they looked at the proportions of people receiving antibiotics, comparing those who received the influenza vaccination and those who did not. And you can see the benefits of influenza vaccination. You go to the next slide. So we are facing a lot of challenges with vaccination coverage rates, not only in South Africa, but globally. So in 2021, 25 million children under the age of 1 did not receive their basic vaccines. And this is the highest number since 2009. The global coverage is reduced from 86% in 2019 to 81% in 2021. We've seen only 25 introductions of new vaccines, other than the COVID-19 vaccine, in 2021. And, if you look at Africa, there are many countries where they don't have the vaccines available that we, for example, have available in our EPI program. Then also the number of girls who's not been vaccinated against the HPV virus or the human papilloma virus 2021 increased by 3.5 million compared to 2019. And then also the number, and this is very scary, the number of completely unvaccinated children increased by 5 million since 2019. So there are definitely challenges when it comes to vaccination rates. So if you look at this slide, this is a modeling study that they've published, and I know it's very busy, but if you look at the bottom of the slide, you will see the purple bars and colors. That's for sub-Saharan Africa, and they are showing the 3rd dose of DTP and the 1st dose of the measles vaccine. And you can see here also 30 million children, which is an additional 8.5 million children who missed their 3rd dose of DTP, and 27.2 million missed their 1st measles vaccine. And we all know we've been facing a measles outbreak in South Africa, and that is absolutely catastrophic when we are thinking of antimicrobial resistance that we want to prevent. You can go to the next slide, Natalie. So I just want to show you our routine immunization coverage in South Africa over the last 5 years. So, I mean, if you look at these percentages, they range between 70-something up to 85%, but we are not reaching the targets. So the fully immunized coverage or child target, according to the WHO, is 90%. And as you can see, in the last 5 years, we haven't reached that target, let alone the 95% coverage required for the measles vaccine to prevent an outbreak. And this is why we are, or why we've seen and still seeing at the moment, a measles outbreak in South Africa. If you can go to the next slide. So now the WHO is focusing more on zero-dose children in expressing vaccination uptake, and there's a huge effort also now in South Africa to look at where are these zero-dose children, what are the reasons for them being there, and what can be done to make sure that they get their vaccines. But it means it's a child by the age of 1 year who has not received a single dose of a vaccine. So that's 9%, sorry. And this is up to 2021. And if I'm speaking under correction, I think it's now 11% in South Africa. So it is 104,000 children, zero-dose children in the country. So there's a lot that needs to be done in terms of uptake of vaccines. So I just want to point out influenza, and we are in the seasons now at the moment in vaccination. But when we look at the mortality burden of influenza and pneumonia, which is grouped together with Stats South Africa, and it is the 7th leading underlying natural cause of death. And it is causing nearly 4% of deaths in South Africa. And you find it is amongst from between 1 and 7 of the leading causes within all the different age groups. And we all know that during the pandemic, we have seen a lower than expected influenza activity in South Africa because of the non-pharmaceutical interventions that we have used during the pandemic. You can go to the next slide. So just to show you with regards to the influenza vaccines, now, we are 67 around million people in South Africa. And, we only get about, say, 1.5 or so million vaccines into the country per year. So during the campaigns, there are certain target groups. But as you can see, by 3 November, which is just more than a month away from the expiry date, you can see we have only used 75% of the vaccines. That's last year. The year before that was 70%. So last year it was a little bit better. And as you can see, it varies also by province. So, for example, the Limpopo province didn't buy any influenza vaccines last year, for XYZ reasons. If you can go to the next slide. So what I want to show here is what is concerning is that healthcare workers are the ones who should really be getting the influenza vaccine, as they expose patients to influenza. They themselves get exposed to influenza, and they work at the forefront. And as you can see, in terms of the distribution, in terms of uptake, it was the lowest for healthcare workers. And then if you look at evidence in terms of research, so we've done 3 different studies, and as you can see, all of them amongst healthcare workers, the uptake of the influenza vaccine, so primary healthcare level at the tertiary hospital and also at old age homes, it was less than a third and as low as 20%. So that is also a concern, in terms of vaccination of healthcare workers to prevent infection. And this is to show you the private market. This is courtesy of Sanofi. Just last year, So what I want to show you is that you can see in 2020 there was quite a demand for influenza vaccines, just at the outbreak of the COVID pandemic. But then it's coming down again. And the issue here is that if the vaccines are being purchased or procured based on previous consumption. So if we use less each and every year, in the end, we're going to get or order or buy less of the influenza vaccines. And the sad part is that each and every year, at least 10%, if not 20% of these vaccines are being written off as expired, which is really a waste of resources. So here you can see Athena's wisdom. So Athena was the Olympian goddess of wisdom and good counsel, war, the defense of towns, heroic endeavor, weaving, pottery, and various other crafts. So this points to what does the future hold and what should we do? Then go to the next slide. Now, looking at the Immunization Agenda 2030 of the World Health Organization, they say that by 2020, we should have a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being, and that no one should be left behind. There should be equitable access and use of new and existing vaccines, reduce mortality. And this is what I want to emphasize now, is throughout the life course. And this is where we should be focusing on from now on, specifically also to prevent antimicrobial resistance and tapping into programs that's already there within the health system to see how we can extend vaccination throughout the life course. And then on the right-hand side, to strengthen our immunization programs to reach universal health coverage in the end. If you can go to the next slide, please. So this is a very busy, hectic slide, but this is what life course vaccination is all about. And as I said, this should be our focus moving forward. Now, if you look, so life course means focusing on having schedules, programs for people from pregnancy right through up to old age, basically, until you die. If you look at the yellow highlighted vaccines, these are the vaccines that we have available in our schedule. There's going to be rubella introduced next year, and hepatitis B, but not universal hepatitis B birth dose, but there will be some hepatitis B birth doses being implemented or rolled out next year. But as you can see, there's a lot of scope still. Many vaccines that we still need to look at. We don't have an adult schedule. There are recommendations, but we don't have an adult schedule. We don't have an official adolescent schedule apart from the HPV vaccine in the public sector schools. And we also don't have a schedule for the elderly person. And these are the people ending up using antibiotics, ending up in hospital. So those are the ones that should be protected through vaccination so that we reduce the use of antimicrobials for secondary infections and prevent antimicrobial resistance. You can go to the next slide. So vaccine safety, I have to mention it, and for me, it links on to vaccine hesitancy, which has become so important during the pandemic. And it's something that we really need to focus on in terms of building confidence in vaccines so that we can prevent other infections. So this is a paper that was published by Heidi Larson and her team, saying that we need to now have a different outlook on the safety of vaccines. So with the use of the internet, it enables a lot of or make it easier to spread information, inform people. But together with that came all the misinformation. So that's something that we really need to look at? How can we build confidence? How can we actually use electronic media, but in a way that we can build confidence? The other thing is with adverse events is people need to understand that everything following vaccination is not caused by vaccination. And then also the immunization stress-related responses, which became very common during the COVID-19 pandemic. And if you don't address those things, it just contributes to the whole spreading of misinformation, creating anxiety around the vaccination, the whole vaccination experience. Then, very important now, all the lessons learned from COVID-19, to put them into actually actions and strengthen our health system. So health system resilience is now very important as we are preparing for a possible future pandemic. So, and then important, absolutely centered to all of this is using vaccination, and then have the health systems in place to be able to deliver those services. If you can go to the next one, Natalie. So this I included it because it's a report that was recently published by the US, but I think it's also very relevant for South Africa. So if you can look here on the left-hand side, they made 12 recommendations specifically in preparing for the next pandemic in the era of antimicrobial resistance. And the whole vaccine development is included in these recommendations. But very importantly, is the social aspects of vaccination and antimicrobial resistance. And I think we have learned now very well during the COVID pandemic is that we cannot only provide people with facts, with science, with letters, with publications or media. We have to look at the context in which this is happening. We have to look at equity, communication, and trust. And we've seen in South Africa also, many challenges as a result of trust, as a result of communication that maybe wasn't clear, communication that kept on changing, and so on. And if you look at these two recommendations that they made in terms of equity, trust, and communication, you will see that we can really associate ourselves with these two recommendations as well. Looking also at marginalized communities and involving them, looking at what are their needs, how are you going to reach them to make this understandable and available to them. If you can go to the next slide, please. So in conclusion, we've seen that AMR, and we all know it's the leading cause of death globally, and it was the highest burden, especially in low resource settings where we don't have all the resources available. The global scale of disruption of immunization services, especially during the pandemic, is significant, but it also provides now with an opportunity for us to address those issues and to prevent, future outbreaks of vaccine-preventable diseases, because we do have vaccines available, but we need to address those challenges in terms of uptake. We've seen and we know now vaccines contribute to combat the growing threat of antimicrobial resistance, and there are many vaccine candidates in the pipeline opposed to our antibiotics pipeline that is running dry. And then lastly, we should all take action. Doesn't matter where you are, where you work, what kind of healthcare professional you are, and then also to empower the community out there, because they are the ones who need to take those vaccines and who need to understand what is antimicrobial resistance. So thank you very much. Yeah, are some references, and yeah, thank you very much for the opportunity and for listening.
Thank you very much indeed to both you, Hannelie, and to Natalie for a really wonderful talk. You've laid out very well the case of vaccination and highlighted a lot of the problems that we are seeing and that we're facing. And I wondered, while we're waiting for colleagues to indicate they've got questions, if Sipo or Tari can just think about the room and pop a hand up. Hannelie, perhaps I could ask a couple of questions while we wait. First off, I was really interested to see that Limpopo didn't procure any influenza vaccination. Is that normal? And has anybody looked at the excess deaths during the influenza season for Limpopo?
Yeah, I don't know about the excess deaths, that I can't answer. But yes, Limpopo faced a lot of problems, and hopefully it will be solved in the future. But it had to do with budget allocations and so on, as far as I know. So it is like, you know, constraints within their system. So hopefully it will be resolved in future. Yeah.
Thanks. And so the second question is, I mean, I always forget this, but I think I'm right in saying that in South Africa, hepatitis B vaccination is mandatory for healthcare workers, certainly is in the UK. With that in mind, should influenza vaccination or any vaccine preventable disease, vaccine preventable infection be vaccinated against for healthcare workers? Should that be mandatory?
You know, to give you an honest answer, you know, when I see what's happening, I want to say yes, it should be mandatory. But when you make anything mandatory, then there are so many other complications to, you know, coming with that decision. And we always believe, and that's what we are sort of advocating, is that it's better to influence people so that they can make the right decision and change their own attitudes and their beliefs. But I know it's very, very difficult. So what you know, what some research has also shown, that once you make something mandatory, then people become more negative and, you know, more anti taking these vaccines. But yeah, it is, and it is, you know, I think to be honest, that's my personal opinion, I think the problem is a lot worse than what we actually think in terms of vaccine hesitancy amongst healthcare workers. I've experienced it now myself, and even among students. Healthcare workers, they will recommend vaccines, but they won't take the vaccine themselves. And even students, we've tried to have campaigns on campus. It's been very, very, very difficult now for influenza. So, and it's become worse since the pandemic.
So just again, before we take the two hands that are up, I just want to push you though, because you're saying our you know, our approach is to try and influence and to try and you know, get people on board, yet hepatitis B vaccination is mandatory. So it's got precedent, and you can argue that we are putting vulnerable patients in jeopardy by not vaccinating against influenza, in the knowledge, of course, that no vaccine is 100%, etc., etc. But I just want to push you, because you're, you know, head of, in your position, you have influence.
Yes, I hear you. So if you, for healthcare workers, because you say you are saying they are in contact with vulnerable patients, which is absolutely correct. So almost to make it compulsory, can I say, within a certain setting. But to make any vaccine mandatory for the whole population, I think that is going to be a problem. But yes, I agree with you.
Okay, that's very different. Okay, I'm going to go to the ID meeting room, and then Esmita has got her hand up as well to come afterwards.
Hi, it's Sipo here. I hope you can hear me. Thank you very much for the presentation. So my question is that you quite clearly articulated the use of vaccines as a tool for AMR. Now that, and you've also quite articulated well that the basket of vaccines is expanding. So the question is, which vaccines would you advocate for, given that money is always going to be a priority? Should we be advocating for vaccines that primarily target vaccine preventable diseases of the respiratory tract, or is it just all vaccines?
That is a good question. Natalie, would you go first?
There has been some vaccines that has been highlighted, especially those for the lower respiratory tract infections and upper respiratory tract infections like Haemophilus influenza, pneumococcal vaccines, influenza. So I think it's different based on, if you look at that static model, it's based on the disease burden or the age group in which you're working, and also the environment that you are looking at. But in sub-Saharan Africa, lower respiratory tract infections, upper respiratory tract infections, and some of the key pathogens has been identified, would be a good place to start.
Thanks very much.
Thanks.
Esmita.
Thanks so much for such interesting set of talks. I learned a lot. I just have it's really a comment, it's not a question, because it is a real dilemma in trying to address people's perceptions of risk associated with vaccines, even as a healthcare professional. So I was vaccinated during COVID, and I vaccinated a lot of people. And, you know, our knowledge about the vaccines improved over time, and the advice I was giving and the confidence I had as a healthcare worker over time increased in terms of convincing people to take the vaccine. But I ended up vaccinating some people I knew just because of the sheer number of people. And, you know, a couple of people I vaccinated ended up having side effects, which could have been as a result of a whole host of things that was happening in their lives, but they associated specifically with the vaccine. Even though in one case, the person later on developed symptoms which proved to be a hypothyroidism. But the point is, how I'm trying to myself understand, how can we do research to learn how we can communicate about the risk and safety of vaccines? Because people always assume, I don't know why it is with vaccines, and you know, we do many other high-risk behaviors in our lives and we don't associate it with outcomes, as we see later on. But with vaccines, that one shot that you get, people associate it with so many different negative outcomes for a long period of time. And I wonder, some of it is the way we talk about the safety of vaccines. We need to change the language and actually work more on busting some of these myths that people have about the longevity of side effects associated with vaccines, which is actually really rare. If you're going to have a side effect with a vaccine, it's most likely to be occurring. Like for me, it's anaphylaxis when I'm vaccinating people. That's the one thing I fear most. But it's just a comment. It's I don't have an answer. It's just very fascinating.
Maybe Hannelie or.
Yeah, you know, it is, I absolutely agree with you. And it's going to be very difficult, but yes, how you speak to people. But I think we have a fundamental problem, and that is that we actually need to start educating from a very early age, from school, about, you know, vaccination, protection, AMR, and those kind of things. School, all healthcare professionals in at university level, and not just there are vaccines and this is the schedule. That's not going to help. We have to bring in these social things and communication. And very important is the journalists. All journalists must be trained in that. It's going to be a very long process, and people need to understand. And then also the people from the WHO, they're actually emphasizing it. is that we've learned a lot during COVID-19 about the adverse events, how to investigate them, and how to do causality assessment and communicate the outcomes. And this is something that we need to continue with and strengthen, and not now go back to where we were previously. Because what we found during the pandemic, when we had to communicate deaths following the Janssen vaccine, because we did it in a very open, transparent way, tried to educate people and inform them, it actually had a very kind of a positive outcome. I mean, it was a very negative situation, but I think it helps, as you say, communicate and how do